And there will be time for questions and discussion after the panel. And I'd like to introduce tonight's moderator, John Rulo. He graduated from the National Catholic School of Social Service at the Catholic University of America in 2020 and has been working with ABLE New Hampshire during his gap year before he continues on to pursue his master's in social work at the Columbia University School of Social Work. As the chair of the Disability Diagnosis Dialogues Task Force, John has really invigorated the work that we're doing at ABLE New Hampshire to improve cultural competence in healthcare. And he's joining us tonight from Portsmouth. And yeah, take it from here, John.
Thanks, Leah. It's great to be here. And I'm so excited for this event. Good evening. My name is John Rulo, and I'm the chair of the Disability Diagnosis Dialogues Task Force, D-Cubed, as we call it. I'm delighted to be hosting this event tonight, and thank you for joining me in both this celebration of a historic event and an introspection into the work that remains in healthcare disparities for the disability community. D-Cube's mission recognizes disability as a natural part of human experience. We aim to collaborate with healthcare providers to improve the experience of individuals and families receiving a diagnosis of disability through the use of balanced narratives and family engagement in the context of understanding that all people possess an unknowable amount of human potential. Now, families beginning their journey in life with a disability routinely report to ABLE that they experience the delivery of a diagnosis in narratives that focus on disability in negative terms and negative life outcomes. This is not surprising, given that the dominant cultural narrative on the construct of disability frames it in opposition to the able-bodied norm. Disability is frequently cast as a life not worth living, a burden, and not quite human. Now, the task force wants to be a leader on the team improving the cultural competence of healthcare providers who serve patients on the journey of life with a disability. Tonight, we hope to inspire you to join this team and to remember this sort of work and collaboration takes to change systems. Our panelists, Dick Cohen, Lisa Beaudoin, Jen Bertrand, and Dr. Erik Shessler have volunteered to share their stories, experiences, and expertise. And I'm incredibly grateful for their willingness and their bravery. Dick Cohen began his legal career as an attorney with Boston Legal Assistance, and then for 11 years with New Hampshire Legal Assistance, where he was lead counsel in the Laconia State School lawsuit known as Garrity v. Gallen. He's since served as court monitor in Minnesota, overseeing, among other things, deinstitutionalization.
John, are you experiencing an internet challenge? I think John may have frozen. Is that the case, Leah? Can you give me a thumbs up if John has frozen? All right, so John might come back to us. And I think we will just say that Dick Cohen was first at the Disability Rights Center after his time at New Hampshire Legal Aid and in the Midwest. He served first as their policy and legal director and then moved into the position of being their executive director, which he served in that role from 2002 to 2015, if I am correct. And we are so privileged to have Dick Cohen here tonight. And
on us back.
Thanks for joining us.
Well, thank you for having me. It's always great to be back in New Hampshire, even if it's virtually. Yeah, just to be clear, I was the executive director of the Disabilities Rights Center, which is based out of Concord and covers all of New Hampshire from 2002 to 2015, and then retired to Martha's Vineyard, where I'm actually the Associate Commissioner for Disabilities here on the island. it's a volunteer position, but seems to have a lot of work. But in any case, what Lisa asked me to do was to kind of spend a little time talking about some of the conditions at Laconia State School when we decided to initiate a lawsuit against the institution back in the late 70s, and particularly those related to health conditions, as well as some stories and issues that I've seen in the community over the years, all of which, when I get into it, sets the foundation for why we need good advocacy on all levels, not just in a one-time way, but on a constant way to make sure that what we achieve initially remains over time and improves. Without it, there can be backsliding, there can be reinstitutionalization, there can be a lot of things which are things that will prove obviously very harmful for folks with disabilities. So my major theme is about the importance of advocacy, and let me just tell you a few things about why that's so critical. When we first went to Laconia, and let me just say that Laconia was in some ways just the beginning, but not even really the beginning, the Laconia State School suit. That suit wouldn't have been possible but for the advocacy of family members primarily, beginning in the 50s and 60s, both nationally and in New Hampshire. It was the New Hampshire Association for Retarded Citizens, as we called it then, the New Hampshire ARC, which is kind of a precursor to Able New Hampshire, that approached our organization, New Hampshire Legal Assistance at the time, it was before DRC was even invented, and asked and really demanded that we file some type of legal action against Laconia State School in the state to principally improve conditions at that point. As we researched other lawsuits and where the whole trend was going, the suit was more about closing the institution and developing a community-based system when we finally filed it. But the suit was filed in '78. We got a massive court order in 1981, and the conditions that we saw, to say the least, were horrific. The way people lived was almost in some ways, at least many of them, equivalent to concentration camps. But let me go over some of the conditions that related specifically to people's health. You talk about health disparities. It was amazing back then. And here are just some examples. Women, particularly, well, through the 40s, 50s, 60s, and even a little bit into the 70s, were involuntarily sterilized when they reached the age of being able to give birth. The Board of Trustees would, and we didn't have like the Division of Mental Health at the time, or it didn't have any oversight over the state school, but a Board of Trustees would typically rule on forced sterilization of women. And again, by the time we filed the lawsuit, this practice had pretty much stopped, but it only had stopped about 7 or 8 years ago. The physicians were very difficult to attract because this was a very devalued population, exacerbated by the segregated and congregate nature of the facility. But the physicians that they did attract would do suturing without any local anesthesia, would extract teeth without any Novocaine. Psychotropic medication was just widespread throughout the institution. Roughly, and we did a study on this for the lawsuit, 40% of the population were on some form of psychotropic medication at the time. And the need for psychotropic medication for a population of people with developmental disabilities is not really much higher than the general population as a whole. And that should be maybe 5 or 10% at most, but yet 40% were on psychotropic medication, obviously as a form of chemical restraint, because there were so few staff. They used physical restraint, chemical restraint, anything they could do to control behavior. And much of course, a lot of the behavior was exacerbated by having been in the institution for so many years. The mortality rate was extensive, very, very high. As I indicated, they couldn't attract really good qualified staff, especially professional staff, which meant that the healthcare was poor, to say the least. There were a couple sort of anecdotal things that were sort of interesting. I remember when but both sides of the case. We were the plaintiffs, and the Department of Justice intervened on our behalf at that time. And together we had 14 nationwide experts who came to the institution, people who were really on the forefront of communitization and closing institutions. The state likewise, because they wanted to match us body for body, also had 14 experts. And when we would tour the facilities, we would tour with each other's experts. And I remember going through the Murphy building at the time, which housed the people with the most severe multiple handicaps, had physical disabilities, probably cognitive disabilities and so forth. And were also heavily contractured and deformed because of the years of lack of physical therapy or lack of any real activity. And I remember going through it with the plaintiffs, the defendants experts, the state's experts, who were some of the foremost people. One was the former the president of the American Association for Mental Deficiency, what was called AAMD, is now, I think, has a much more progressive name. But it was sort of the equivalent to the AMA for disabilities. And I remember him taking, and another person from a professor from BU, a little small flashlight, looking into the eyes of the residents of Murphy building who were in cribs and so forth, even though they were adults, and seeing if they were really had, if there was any real activity. I mean, they were sort of thinking that maybe they were in comatose states, which was very chilling, to say the least. When we brought our experts through, and I remember one most notably, through that same building, a woman named Karen Green McGowan, who maybe some people know. She testified in a lot of cases and was a wonderful nurse and wonderful human being. I remember going through Murphy building with her, and she said, well, you know, I think that maybe 25% or maybe even up to 50% of the people in this building probably aren't even intellectually disabled, which of course was in complete contrast to the view of the physicians that the defendants had brought in. And the reason why she said that, most of these people had severe cerebral palsy and didn't have verbal skills, and looked in very poor condition, in part because of their CP, but in large part because of the years of atrophy and so forth. But I sort of scratched my head, as progressive as I was. Is she really kidding, or is this for real? And of course, as I became sensitized over the years, I found that, of course, there are many people with cerebral palsy who are intellectually fine and as bright as the rest of us, something apparently that the defendants experts didn't know, but at least our expert did. So that was indeed very revealing. We also had a very wonderful expert. Some of you, I know the doctors here may know, is a fellow named Alan Crocker, who for years was the head of the developmental evaluation clinic of Children's Hospital, and was a wonderful physician and one of the pioneers in developmental disabilities from a medical point of view. So in any case, we went to court and we got a sweeping court order in 1981. And that didn't necessarily call for the closure of the institution. It required that the institution get down to at least 250 people. There were 600 when we brought suit. And it was based on a plan initially developed by the state and chiefly by Don Shumway to develop community services so that we could reduce the size of Laconia and then ultimately close it down with sufficient community services. We recommended that the court adopt the state's plan. The court did with our revisions, and that really became the blueprint for ultimately what resulted in the closure of Laconia State School. So that was in 1981, and things went pretty well. A lot of lawsuits of this kind, there have to be contempt actions because the state won't comply, but we got pretty good compliance for the years that the decree was in effect. And then as a result of the suit and the work of a person like Don Shumway, we were able to ultimately close the facility in 1991. And we became the first state in the country that had a complete community-based system of services. And that was in 1981. Well, rather 1991, 10 years later. The problem was that beginning around that time, shortly after the closure, there started to be slippage, which I'll get into in a minute. But I just want to give you a couple sort of anecdotes and stories about which symbolize the need for vigorous advocacy, and also symbolize the kind of slippage that can occur if you don't have vigorous advocacy in a system of services. One was a woman who was at a place called BRI, that are now called JRC, Judge Rottenberg Center. At the time I was the head investigator at the Department of Developmental Services. This was in the 90s. And this was a woman who had pretty significant behaviors, but nothing really dangerous. And that particular facility used all sorts of aversives on folks with even minor behaviors, cattle prods, ammonia. They had hot sauces and hot peppers they'd have to swallow if they engaged in any behavior that the facility thought was aberrant. And this is in the 80s and 90s, and in Massachusetts and Rhode Island. This particular woman that we ultimately investigated was having more behavior issues than usual. And they assumed it was because of her being a bad girl. And so they increased the aversives on her, giving her pneumonia, giving her various sorts of, and this was the nurse recommending as well, giving her various aversive tasting type items. I don't remember precisely at that point, hot sauce and so forth. And so at some point she just passed out. They rushed her to the hospital, and she had for the past 3 or 4 days a perforated ulcer. And that's why she was in such pain, and that's why she was acting out. She subsequently died at the hospital from sepsis. And again, this is theoretically a community placement, but one that has really all the trappings of the worst kind of institution possible. Let me skip for the sake of time to, I was going to mention 3, but to one other one. This occurred not long ago in New Hampshire, in Concord, New Hampshire. I was representing a woman who had actually been at Laconia, who was having her yearly service agreement review to see what she needed. She lived quite independently in the community, and someone I had known for many years. And we went to the meeting, and at the meeting I learned that she had pain in her teeth for a number of years, but the area agency wasn't doing anything about it because there wasn't Medicaid covering it. So I advocated that you needed to find money someplace and find it soon to deal with this chronic and acute pain. And that was written into the plan. So I went back to my office shortly after the meeting. It was in Concord, New Hampshire. My office was at 18 Low Ave, not far from the area agency office, and happened to turn on a website from the Developmental Disability Council out of New Hampshire, rather out of Minnesota, very highly regarded, well-known, and I'd worked in Minnesota for 4 years and developed a close relationship with them. And they had developed a historic analog of folks who had done tremendous work in the developmental disability field since the 70s. And several of them were experts who had testified in Laconia, including a fellow named Mark Gold, who was one of the leading pioneers in developing supported employment for people with disabilities. In fact, his organization, he's since passed, but his organization is called Try Another Way. And I looked at the video, and it was a very famous video that we actually showed at this Laconia State School suit. And it was of a fellow who had profound intellectual disabilities, which is the large, horrendous institution in Illinois. And Mark was at the facility. He asked the superintendent, give me your toughest person. And it turned out to be this fellow who had profound intellectual disabilities, was deaf, and was blind. And one of the things that Mark did was, through task analysis and so forth, help folks perform various tasks. And one of them was putting together a brake assembly for a bicycle. And there's 18 different individual tasks to do that. And Mark, within a half hour, had this fellow, and then the video showed this, doing 10 of the 18 tasks completely independently, someone that they had labeled with a 20 IQ who was deaf and blind. And I sort of sat there, and this was now, about 30 years after the lawsuit and about 40 years after this film. And here I'm going to a meeting for someone who formerly was Laconia, who can't even get good health care for her pain, And so I said to myself, how far have we come, or how far have we come down since the lawsuit. So that was a kind of depressing time for me, looking at where we had been, what our expectations were, and we were still trying to battle to make sure someone could deal with the pain, and a very difficult pain in their teeth, and people know what toothache was like. So those sort of symbolize, some of the slippage that had occurred. We still hardly had a perfect system, and why we need good advocacy. And in a moment, I'm going to tell you some of the ingredients that I think make up good advocacy groups. And here I'm talking primarily about systemic advocacy. In other words, doing advocacy to make sure that the system is responsive. Individual advocacy, representing people or advocating on behalf of individual families and individuals with disabilities, is just as important. I mean, people know far better than I, if you had family members, how you have to spend at least 3/4 of your day advocating just to get basic services. That's critical, but systemic advocacy is important too, because those are the ones that make the system more responsive. But the point I want to make is that advocacy is critical. It does help to have good leadership in government. And I'll give you 2 examples. Laconia, I already gave you. I think we wouldn't have closed Laconia as quickly as we did if we didn't have good leadership at the state level in a guy named Don Shumway. A few years ago, some of you may remember that DR Disabilities Rights Center took on a place called Lakeview up in the North Country. And we did a major expose on the horrendous conditions at Lakeview, which was housing maybe up to 75 to 100 people, again, segregated people with the most significant disabilities, behavioral issues, and so forth. Karen Rosenberg of DRC did an amazing expose and white paper on that facility. And we made a number of recommendations. Within a month or so, or even less, because we had a really good governor and who was pretty sensitive to these issues, that place was closed down. And the governor was Maggie Hassan, and the place was closed, as I say, in 1 month of our recommendation. So leadership is important, but even with the best of leaders, and you can't find any 2 better than those, especially for this issue, they have competing interests. They have a lot of things. Maggie took the pledge. Don became head of Health and Human Services and had a lot on his plate. So even with the best, it's critical to have good advocacy. And we know what some of the systemic issues were. After 1991, when the place closed, the waiting list started growing. Family support to families started growing. Placement in people's own homes started disappearing. Supported employment, which started out well, started flattening. We had issues with wages for persons with direct support staff and so forth and so on. We did a white paper at DRC which showed that care for people with the most significant disabilities was deteriorating. As a result, we had some very untimely deaths. So all of this occurred after Laconia closed. It was still far better than Laconia for virtually all of the people out there, but it wasn't what our expectations were. So what did we do? We engaged in advocacy on the legislative level. A good example is the family support legislation, followed, I think, in around 2008, SB 138, which some of you know. I see Bonnie's there, Larry McRae, and so forth. I'm waving to Bonnie too. I don't know if she sees my wave. That ended the waiting list. It said, or it reduced it significantly, saying that the legislature shall appropriate sufficient funds for the wait list. We established again, through good advocacy, not a lawsuit. It's difficult to do a lawsuit when everyone's dispersed. It's easier when they're in one targeted institution, but through good legislative advocacy, that bill not only ended the wait list, but also created a quality commission to look at the quality issues, the DSP issue, the employment issue, many of the other issues that weren't quantitative, but really address the quality of life of people with disabilities. So the Quality Commission was established and made some headway, not as much as I would have liked on some issues, on employment, a little bit on managed care when that came up, on the DSP issue, direct support staff, and several other issues. And we did this all without the benefit of a lawsuit. So that's why we continue to need advocacy. People with disabilities continue to be devalued. There's competing claims even on the best of leaders. And let me end with just what I think requires what characteristics are necessary for good advocacy groups. One is that you have to be multifaceted, whether that's yourself alone or in conjunction with other people. If you look at models like the NAACP, the women's movement, legislation's critical. Look, we're using now the Ku Klux Klan Act of 1871. So legislation is very critical, but it has to be enforced. Lawsuits are important. Enforcement of legislation is important. Grassroots work, legislative work, it's all critical. You have to be multifaceted. The other thing you have to be, whether that's you alone or you in conjunction with other groups, it has to be independent. A good advocacy group has to be independent from people who might have conflicts of interest. And I know that was an issue when we, I think, formed ABLE and other groups. It's important to have the membership made up principally, if not exclusively, of individuals with disabilities and families. You can coalesce with other people, just like you are on this issue, on issues of mutual interest, such as funding. Everyone wants more funding. Area agencies, everyone wants it. But you yourself have to be pure and free from conflict of interest. You've got to be strategic and smart. Use of media, good planning. You got to prioritize, but that's a critical a critical component as well. So those three things: multifaceted, independent, being smart, being strategic, being made up of people who are really being affected, are all things that we need. And that advocacy has to be constant, because over time things slip. We don't get what we always want, and good advocacy has to be there. There's a lot at stake. It's not just the quality of life of individuals, but also we're experiencing, as I said at the outset, this trend for reinstitutionalization. Lakeview was that, because the area agency system in this and other states wasn't doing the job with people with significant complex disabilities. So there was a market for a place like a Lakeview. Many families, because they aren't getting what they need, and individuals what they need or what they think they need, are forming these enclaves of congregate communities throughout the country. And that's what happens when the community infrastructure fails. So it's important to work on that community infrastructure, so it's providing basic good care and custody, but not custody, but more importantly, good quality of lives, things like important choice, employment choice, and just an enriching quality of life. And without advocacy, that's not going to happen. And I applaud ABLE for the work it's doing. And I think we all have to up our game in every state to make sure that we maintain what we have and improve upon it. So I'll end with that and look forward to the other discussions and the second part of this.
Dick, wow, thank you so much.
Mm-hmm.
Wow, just an incredible account. Thank you. I apologize for my brief hiatus, but we're back. And Lisa Beaudoin has been Executive Director of ABLE New Hampshire since 2017. Her work includes influencing public policy, community organizing, and overall organizational development. She's also serving her third term as chair of the New Hampshire SAC, a federally mandated statewide committee advising the Commissioner of Education on the education of students with disabilities. Lisa, thank you.
Thanks. Well, I'm really excited for everyone who's joined us tonight and very grateful for the panelists. I am intimidated to follow Dick Cohen, but here we go. Originally, Dr. Susan Zimmerman was going to discuss her qualitative research for a book she's working on, which circuitously led her to become the first chair of the Disability Diagnosis Dialogues, which is why we're here tonight. Her work is examining the lives of mothers raising children with disabilities to shed light on how these moms negotiate, manage, and approach their daily lives within the context of systems that are continually at odds with the hopes and dreams that moms have for their kids. So Dr. Zimmerman wasn't looking to write a book about the biased delivery of diagnosis of disability, but this pattern emerged. So the pattern of healthcare providers delivering subtle or overt expressions of their personal bias against life with a disability became a theme during her interviews of women. And they were from a wide variety of socioeconomic and geographical backgrounds. the parents repeatedly reported experiencing a lack of a conveyance of hope, the constant painting of a bleak life, that is life with a disability, and that the parents' lives would be burdened. So she noticed that those were 3 recurring messages that parents reported. So I have a quick story that she shared with me. One of the moms, upon receiving a diagnosis of Angelman syndrome for her baby girl, related that all 3 of these messages were communicated to her in a single medical appointment. And that was pretty disheartening for that mom, and it did not set her off on the right footing in this new journey of life with a disability that she was about to embark on. The girl now, however, is a teenager, and she is a cheerleader. She's fully included in general education classes, and she has a robust, meaningful life. But mom had to navigate in opposition to the messages she had received early on. So Abel routinely hears stories about families experiencing the delivery of diagnosis of disability and narratives that focus on disability in negative terms and life outcomes. So this is not surprising, because that's the message all over mainstream society. It sort of frames disability as less than. And so families are beginning life in the journey with disability, and there's a different narrative out there, right? It's really important that we find and promote that alternative narrative on disability, right? And that alternative narrative is a key part of the secret sauce to creating a good life for people with disabilities. Like all of the work that was done in the 70s and 80s and early 90s to like make sure that people in New Hampshire were not relegated to a life in an institution, that picture that Dick was painting, in order to be able to continue manifesting the vision, right? We need to continue to elevate this other story on life with a disability. And here's the secret sauce. The secret sauce is that individuals not yet impacted by disability actually have to believe that life with a disability is worth living, and that people with disabilities can and do lead dignified, meaningful lives, and they make contributions to family and community and society. Because we know from the drill down data that when individuals with disabilities have people in their lives who believe in them, the data is clear. Outcomes in all metrics go up, whether it's inclusive education, whether it's supported employment, whether it's civic engagement. In all metrics, when people with disabilities have a framework of a life with a disability as being worthwhile, then the people who believe in them buoy that to the good life for people with disabilities. Changing the paradigm on what to expect in order is difficult, right? So we need to change the paradigm in order to implement strategies to get those improved outcomes. And healthcare providers are indeed an important partner in changing that narrative on disability, if people with disabilities are to reach their true potential. Because families who start off that journey in life with a disability more frightened than when they walked into the doctor's office are going to have a tougher time finding the resources and the hope and the tools for getting their person with a disability what they need to be staged for success, right? So one of the problems is that currently medical schools and other healthcare training teaches that disability is a health outcome, right? However, currently federal healthcare policy is trying to pivot that framework to disability as a population of actual people, right? Not as a health outcome. So we want to make sure that on the ground here in New Hampshire, that our healthcare providers are getting the tools that they need and the partnerships that they need in order to help pivot that one little bit of a misunderstanding. And we want to take the vision that's in the healthcare policy of disability is a population. We want to take that vision and make it real. So the other interesting thing that's happened is in 2017, the American Medical Association recognized publicly that medical students and residents do not receive training specific to the needs of the care of people with developmental disability. So the American Academy of Pediatrics introduced Resolution 315 with specific goals calling for the inclusion of developmental disabilities curriculum in undergraduate, graduate, and continuing medical education of physicians, right? So if properly implemented, individuals and families first encountering a diagnosis of disability will be better positioned for improved life outcomes if given than if they were given a negative narrative. So we know from the literature on disability and cultural competence that to enhance the experience of healthcare consumers requires that healthcare professionals be exposed to people with disabilities during their training, as well as to collaborate with community-based organizations. The research on that, that kind of partnering demonstrates that it provides voice to people who experience disabilities in their home communities, and it improves the experience of people with disabilities in healthcare settings. So the Disability Diagnosis Dialogues Task Force is super grateful for tonight because it's a second big event where we have collaboration with healthcare providers. We're really excited that Dr. Schessler is here, and we are trying to collaborate with medical teams all across New Hampshire to present more balanced and accurate narratives on life with a disability. And we know that through these kinds of partnerships, healthcare professionals and disability advocates can effectively make New Hampshire the shining jewel in the experience that people have in healthcare settings. We want New Hampshire to be the gold standard for cultural competence in healthcare. Thanks.
Great. Thank you so much, Lisa. Jen Bertrand is Director of Community Partnerships, Community Crossroads, New Hampshire. Jennifer provides information and training and works to further the dignity, inclusion, and civil rights of people with intellectual and developmental disabilities. She's a passionate advocate for her daughter and others on public policy issues related to education, healthcare, Medicaid funding, housing, employment, and human civil rights. Jen, thanks so much for being here.
Well, thanks for including me this evening, and it's such a it's so exciting to see so many people tuned in this evening, and also to hear from Dick Cohen about some of that history here in New Hampshire and how critical it is to continue to support the advocacy and training advocates to do this important work. And for some, like myself, I'm a mother of a daughter who's now an adult who experiences a developmental disability, to be working within these systems to also ensure that they truly are serving the people that they were created to serve. I'm going to share with you a personal story about when we received Chloe's diagnosis, my daughter Chloe, and unfortunately she's doing some other things tonight with her dad and her brothers, so she won't be popping in. And then recently, a challenge that we had finding a specialist that was a medical specialist who was culturally competent. So it was in my late 20s when Chloe was born. She was my second child. And well visit after well visit, I shared and expressed my concerns about her delays, her extreme fussiness, all along that first year of her life. But my concerns were often dismissed, sometimes met with condescending remarks, despite the fact that, she had been missing every single developmental milestone. And then finally, at the 1-year visit, I insisted on a referral and inquired about obtaining some developmental evaluations. At that point, Chloe wasn't able to get in or out of sitting. Or even if I put her in a seated position, she didn't have those automatic reflexes to be able to put her hand out to stop herself from falling over. We were referred to a neurologist and connected to Easter seals, and Chloe's developmental evaluations revealed she was significantly delayed in every area. A local neurologist met with us once and ran some blood tests, and at the next well visit with the pediatrician, he informed me that all of her tests had come back normal. You know, it wasn't a wide variety of tests, but the tests had come back normal. And I'll never forget the statement, and I quote him, this may have been what God has given Chloe, Mrs. Bertrand. You know, and I was just stunned. I was like thinking to myself, what kind of diagnosis is that? So the pursuit for answers was slowly drawn out over the next 5 years. And at one appointment in Boston, a specialist, we were meeting with them. He had reviewed records. We were having a conversation, and he all of a sudden inhaled sharply and grimaced dramatically with disapproving brows when we shared that, you know, Chloe would get into her garment, and sometimes she would smell her fingers, and he had the stern, like, uh-oh. And I'll never forget this. That's when he said, you know, oh, she might be mentally retarded. And, you know, he kind of just shook his head like in disapproval. And it made me catch my breath, and just a feeling of dread and washed over me. And, you know, I was constantly plagued by fear and uncertainty after that about what it meant, especially because of his response. When she did receive the final diagnosis of autism, it was delivered just before Chloe turned 5. And you have to remember, she was born back in 1999. And she was a female, and female, you know, are far fewer, you know, far fewer females, or at least at that time, were diagnosed with autism than males. So maybe that was part of the reason why it took us that long to secure a diagnosis. I left the doctor's office that day after receiving the news, and, you know, I was feeling extremely overwhelmed and hopeless, you know, as if all the dreams and aspirations I had for her suddenly evaporated. And it was hard to imagine, like, how would I have a professional future, you know, given the level of support and care that she needed for all of her activities of daily living, and, you know, the behavioral needs and challenges that she experienced, and challenges with communication. So it was a really difficult time. We were not provided with sufficient resources as a family, only a simple pamphlet on autism. And, you know, we just were quite stunned. Initially, I had a hard time accepting the diagnosis because if you are, you know, remember back in the day, you know, there was a stereotypical Hollywood profile of someone who had autism. You know, if you saw the movie Rain Man, you know, and Chloe wasn't a savant. Her presentation was a lot different in many ways. But once the initial shock wore off, I was determined to do everything I could to help her reach and exceed her potential and to live a great life like my other children. Um, In the early years, many of her doctors had very low expectations for what Chloe might learn and what she might accomplish. But we worked day and night at it, and advocated every step of the way. Often at doctor's appointments, they would describe raising a child with an intellectual and developmental disability to be very burdensome to parents. However, you know, Chloe's life today was nothing like what was initially described to us. We have made sure that she has been afforded all the same opportunities as her siblings and her peers, you know, and our neighbors' kids in our community. Her life is rich and full. We fought for high expectations in her academic inclusion in the local schools. And at one point, and probably because, you know, I had the opportunity to do like the Institute on Disability Leadership Series. You know, we have such great resources like the DRC and the Parent Information Center, which helped me get the information I needed to advocate for her so that I could secure the supports and services she would need so she would be able to grow into her full potential. so we stopped at some point, and we, instead of saying, you know, can she do this? We started asking, what supports and services will it take for her to be able to do it, for her to be able to be successful? And we enthusiastically advocated for the necessary supports in all the different service systems. As parents, you're advocating in the community-based service system, you're advocating in the medical system, you're advocating in the educational system. I mean, it's just, I mean, I think Dick described it very well in terms of the amount of, you know, time you spend in a given day, you know, on your individual advocacy. But we can't be lost in that. We have to have systemic advocacy as well. Because of that advocacy and our belief in her potential, and Chloe was able to grow up at home, day to day, with the love and support of her family. She attended her local public school. She had an inclusive educational experience. And as a result of that, she made meaningful connections in the community. When it's not COVID, you know, you go everywhere, people always know Chloe, you know, and people will say hi to her. I don't even know who they are. And so, you know, because she was able to develop a sense of belonging in her community. She, when it's not COVID, she volunteers, she enjoys all sorts of recreational activities, participates in civic activities, and she's a powerful self-advocate who really has earned the respect and consideration of lawmakers, and is working herself with the support that she needs to craft a better future for people with disabilities. During her final 2 years of high school, because she's 21 now, Chloe got a job at Whole Foods, and she worked within the supported employment model. And she's had to take a leave of absence because of COVID, and she was transitioning into adult developmental services during this pandemic back in August. And we were really, you know, challenged, like, what is her life going to look like? How can we, you know, continue to support her when, you know, she's had to stay sheltered from everyone else because of the medical issues and needs that she has. So Whole Foods is, you know, going to welcome her back once the pandemic is over. But we discovered in high school she had this keen interest and passion for shredding paper, and with our support, she was able to open her own small business, Chloe's Shred Shed. She's passionate, and she works, you know, at least a few hours Monday through Friday, sometimes on weekends. But it was a real challenge to initially obtain her medical diagnosis when she was a child. And it was even more challenging finding doctors and specialists who really did have the understanding and cultural competence and interest in working with adults with more significant disabilities. And it's, while, you know, in a lot of ways, I think on the developmental side of things, and pediatricians are a lot more informed than they were when Chloe was, you know, born and in her toddler years. We still have, you know, now that Chloe's an adult, we've discovered there's still some challenges for specialists that serve adults. About 2 years ago, Chloe started experiencing uncontrollable jerky movements in her extremities. She was falling down for no apparent reason. It was a long time since she had been seen by like pediatric neurology, because she, you know, after turning 18, they really do expect you to transition to, you know, adult specialists. We sought one out to get more understanding of what was going on. We saw an adult neurologist twice in Manchester. And at the second visit, she told us Chloe was too difficult to evaluate because of her disability. And she basically dropped her as a patient. And again, we were stunned. We didn't know where we were going to turn, how we were going to find answers. So I begged the neurologist to contact the pediatric neurologist that had been with Chloe since 3 to see if they would agree to see her, even though she was, you know, 20 years old. She did agree to do that, and we were able to get into seeing the pediatric neurologist. Within like 10 minutes of the visit, I brought video of what was happening, where she would have these movements. The neurologist was able to diagnose Chloe with myoclonus. We did a 24-hour EEG to confirm that it was caused by seizures. He also ordered a blood workup of some new genetic testing that wasn't available when she was younger. And since then, she has been also diagnosed with a very rare perioxome, peroxisome, still very new, this diagnosis, I can't even pronounce it. We're working with some researchers in Canada who are studying this to find out more information and see how we might be able to continue to help her. There are distinct challenges to raising a child with a developmental disability. And I guess my message to parents and to the medical professionals out there, that it's okay when you're delivering a diagnosis to offer, in fact, it's critical to offer hope when conveying uncertain information. You can be honest about, the fact that it is uncertain, but you can also give hope. And there is a distinct need for increased cultural competency for medical doctors and specialists, especially adult specialists. Chloe's an adult person, so she really does need to see an adult neurologist that really understand the neurology of adults, but also have that experience and training with individuals with developmental disabilities. She's an adult, even though she might developmentally be young, she's still an adult, and we need those types of professionals in the field to ensure that people like Chloe can receive the care that they need, and be healthy, and we can address that equity issue around the disparity of health outcomes for people with developmental disabilities. When individuals and families are well informed and empowered and know how to advocate to access the things that their family member needs, so that they can receive an inclusive education, community services that, are needed for them to live a meaningful life, an inclusive, meaningful life, and are also offered hope despite uncertainty. That's when they feel empowered, and that's when they can live a meaningful life full of possibilities. So at first contact, if you're a physician, whether you're in the adult realm or in the developmental realm, pediatric realm, it's so critical to be able to offer families and individuals resources to also offer hope, in addition to the particulars about, it doesn't mean you don't have to share the realities of, some of the challenges that are associated with that diagnosis, but you can offer hope. Disability is a natural part of the human existence. And sometimes a limitation can help make us limitless. So thanks for listening to our story. And I was happy to share that and be here tonight with all of you. Thanks for listening.
Jennifer, your story is so powerful. So thank you so much for being here. Thank you. Dr. Erik Shessler is the president of the New Hampshire Pediatric Society and associate director of general pediatrics at Dartmouth-Hitchcock Hospital. Since receiving his MD from McGill University in 2005 and completing his residency at Dartmouth-Hitchcock, he's been a leading voice in pediatric healthcare in New Hampshire. Dr. Shessler, thank you so much for being here. Please.
Thank you very much for having me join. And first off, let me say thank you, Jennifer, for that powerful story. I think when we're thinking about how we can improve things within our healthcare system, it starts with recognizing the importance and the passion and the advocacy and the amazing work that families and patients can do to help us out. I think when you're hearing the stories that Dick was saying before, the stories that Jen just shared, that Lisa shared before, you don't go into healthcare wanting to provide, suboptimal care. We want to do better as a healthcare kind of group. And I think the ways we can is by hearing the stories about the times when we haven't been as successful as we need to be. And then trying to make sure that we're identifying how do we make sure that this improves so these situations don't happen again. So again, thank you very much, Jennifer, for sharing that story. It's incredibly important for us. So I'm a general pediatrician. And so currently I'm the president for the New Hampshire chapter of the AAP, which used to be the New Hampshire Pediatric Society, same kind of organization. And what I've been passionate about doing within my primary care practice, within my practice at Dartmouth-Hitchcock, and within the New Hampshire chapter of the AAP, the American Academy of Pediatrics, is making sure that we're championing patients and family stories. So I've gotten a chance to do that in my work, my work life, and just hearing those stories is amazing. And I always kind of joke that that meeting constantly makes me go, oh my goodness, why didn't we think of that? Why didn't that come up before? That should be something we should have thought about. And the answer is we didn't necessarily think about it because we didn't ask patients. We needed to hear the stories for patients and families that we work with to identify what we're doing well and what things we're not doing well, and how do we continue to move forward from there. And so working with patients and families, working with, kind of into improving our family engagement, making sure that we're partnering with our community organizations. Quick shout out to New Hampshire Family Voices, who I saw who's on the line, who we've gotten a chance to work with repeatedly. So thank you for their work, Enable New Hampshire, to just make sure that we're doing this not just on an individual level as practitioners, as pediatricians, adult practitioners, but moving beyond this and looking at it as a state. And so tonight, I happen to be joining from the New Hampshire Pediatric Society and chapter of the AAP, but we're also working with the New Hampshire Medical Society, working with making sure that we're working with our adult colleagues that are in primary care, in specialty care. So how can we make sure this message gets out so that we can consistently move forward? So clearly there's work that's left to be done. And I think Jen highlighted a whole bunch of things that we could have done differently. Dick highlighted a whole bunch of things that the healthcare system has failed to do over time. And so I want to spend a little bit of time just highlighting some of the things that we've attempted to do to improve situations over time. And that'll lead us to some opportunities and some discussions that we can have in our breakout sessions about things that we can continue to do and ways we can continue to improve. So one option, one example I wanted to be able to use is talking about advocacy and advocacy training. During my residency, I got a chance to work with what we used to call the OIL program, which is training our pediatric residents at Dartmouth about how to think about population health. And so I liked the point we made before, thinking about disability as a population of people. How can we make sure that we are keeping all populations as healthy as we possibly can? And so learning a little bit about identifying and thinking about population health, not just about necessarily the patients that are in front of you. Well, what's best for the community? What kind of services do we need? How do we make sure we're improving our coordination? Thinking about care coordination. So I think that's a perfect example. So care coordinators are so critical to pediatric care, to primary care, and to healthcare. And frankly, 20 years ago, there were very few of them. And now having a primary care office, it's unusual to not find somebody who has served some form of care coordination role. And so there's clearly been some growth with regards to identifying what we can do better as kind of a group. Dick mentioned advocacy as a piece. When I went through my training, and that was 12 to 15 years ago, I got about half a day's worth of training on advocacy. And now some of the pediatric residents through Dartmouth-Hitchcock actually get a chance to do multiple days of advocacy, including going down to the State House and getting a chance to work with some advocacy groups down there, get a chance to meet with legislators, get a chance to realize how do you go about being part of a deposition, or how do you go about being giving your opinion and making sure that your voice is heard consistently. And it's such a powerful message, and working with community organizations and families makes those messages that much more powerful. So I wanted to highlight that we got a chance to do that. Another kind of one that we've mentioned, and since Lisa brought up that training hasn't necessarily been as good as we wanted it to be, we've been able to partner with Vermont and Maine and to create something that we call the Northern New England Advocacy Collaborative. And so it's actually a partnership with the pediatric residency programs in New Hampshire, Maine, and Vermont, talking about what advocacy efforts and champion programs do we need to be able to do. How can we highlight what medical students are doing, what residents are doing, capitalize on their passion, and make sure we're able to kind of move forward with some great novel ideas for how we can kind of help out from that standpoint. I also wanted to give a quick shout out to Forrest, because he put a quick comment in the chat that was fantastic. He mentioned that folks may think I have a disability, but I don't. I have different abilities. And I think figuring out those types of messages so that we can make sure that we're delivering cultural competent care is so important. Again, we are professional learners. We all want to continue to improve in our practice. And this is just an area that I know I can improve. It's an area I know my colleagues can improve. And then clearly, as we've highlighted, it's an area that our specialties can improve, that our adult colleagues can improve. We all have work to be done. And I think there's some wonderful opportunities, and getting a chance to take a minute to hear, what things have been worked in the past, how we've been able to work together to work towards the, closing of the Laconia State School, getting a chance to champion some of the patient stories that are out there really gives us an opportunity for us to continue to grow as we go forward.
Thank you so much, Dr. Schessler. So powerful coming from, a medical provider yourself. So thank you.
Thank you, Dr. Schessler.
And thank you so much to our brilliant panelists tonight. We have time for a few questions before our breakout rooms. So feel free to raise your hand or throw something in the chat, and Leah and I will do our best to make sure everyone gets heard.
I have a question. I'll kick it off while everyone else is thinking about their questions. So, Dr. Schessler, I am curious about accountability. So if we are to be doing storytelling and CMEs, continuing medical education workshops, and trying to elevate this idea of cultural competence around the care of people with disabilities when they're experiencing, when they're in a healthcare office. So if we're doing this, work, how do we continue to build strong alliances with healthcare providers, hospital systems, and associations, but also bank in some accountability and some measures on our progress in that vision of really excellent cultural competence in disability? How do we do both and not sever relationships by having some accountability measure?
It's a great question, and I don't have a perfect answer for you, but I can give some examples that would allow us to think about options of how we can build off that. So, for example, using a slightly analogous kind of setup, there's a lot of work that we do with regards to healthcare literacy. And that's a term, for example, that we use to say, how do I make sure that when I'm talking to families that I work with and patients that I work with, how do I make sure that I'm actually doing a good job of translating, so to speak, some of the things that I'm trying to communicate with. And same, I want to make sure that the patients feel like they're heard consistently. And so one of the big things that healthcare has been able to do over time, and it's still not perfect by any stretch of the imagination, is work on patient satisfaction type of scores. And so getting an idea of that now you can look online and figure out right now, based on Googling my name, how well I do with patients feeling like they feel heard when they come to visit me. It's public knowledge that you can see to look at an idea with regards to providers about how well they do explaining things in the office, how well they answer questions that are going through. And that's where I think a little bit of that accountability comes in. Now, we haven't built that for cultural competency yet, but it's along those same kind of lines, that it is now expected and it's public knowledge that I get rated on how well I work with patients and how well those interactions go. My bedside manner has a great deal to do with how well, those communications and those relationships go. And actually, I paused with there when I said that my care is a part of how people stay healthy, and only a part. And that's actually a piece to that scenario. So I think, we mentioned a little bit before, working within that, kind of paradigm, that I'm the medical portion of this. There's the health, the education system. There's the community agencies that work with families. There's the community that you live in. There's the family and the home that you work with, your loved ones, the folks that are there consistently on a regular basis, that the medical team is just a small part of what a person's, kind of health really is and what health looks like for each individual. And so I think being able to find a way of having that consistent message is important. So the patient satisfaction scores is kind of an example. So I think we would look at it in a couple ways. How do we make sure, A, that cultural competency is there and presented to healthcare providers? Make sure the training happens and make sure it's expected that people stay up to date with regards to what they're coming up with. The state now requires, continuing medical education credits on opioid use because there was an opioid crisis in the state. That made a great deal of sense. And now there's actually accountability. I have to prove that I do the education, that I know how to talk about pain without necessarily going directly to opioids. And you could go out, in a similar direction with regards to cultural competency. And so I think those are just kind of examples. So it's, a long answer to be able to say, I don't have a perfect answer yet, but there's some building blocks in place that we can work with.
If I could comment on that a little bit. Am I on? Huh? Hello? Oh, I'm unmoved.
Oh.
Dick, you're muted.
You muted yourself.
Hello?
There you go.
Okay. I agree with everything there. In fact, I'm a very activist consumer myself. When I have to go to a doctor for sports injuries or for anything, I look at Health Grades MD, WebMD, Yelp, you name it. There's about 6 or 7 that I typically look at. So I agree that that's good, a good source of information. One other thing I'd mention, and this is kind of a very last resort, but in terms of accountability, and at DRC, we did a number of cases and probably still do, although less now because I think hospitals and physicians have learned their lesson, is especially for the deaf community. There were many hospitals who weren't getting interpreters, and there's now video relay interpreters. There's easy way and not very costly ways to do this. Doctors who wouldn't do that. And so therefore the deaf person wasn't understanding what was being said to him or her and couldn't communicate back. We did several, after making demands, several lawsuits to address that, not for damages, but generally to get the hospital to correct their practices and make sure that they have interpreters, because that is a reasonable accommodation. The person, in order to effectively communicate, needs an interpreter. And so we did it on the basis of the ADA, which requires both government and private parties and businesses to make reasonable accommodations so the person can benefit from the service. So in the example that Jennifer gave as a lawyer, of course, for many years, when the adult neurologist wouldn't do the examination because of whatever issues he thought made it too difficult for him to do the neurological examination, the first thing that popped into my mind as a lawyer is, well, this would probably be a violation of the Americans with Disabilities Act. You don't know, that's not the first thing you should do, and there are other ways to do it, but it is part of the toolbox that consumers, might think about. Powerful and rich people use litigation all the time. We had a former president that did 60 lawsuits on nothing. So if there is, a particularly blatant issue where a person is denied service, that's certainly a remedy that's available under the Americans with Disabilities Act, which is a piece of civil rights legislation.
And actually, I'll point out, given the example you just provided, the medical system that I work for, every year, each provider within the system and each healthcare worker within the system has to finish an electronic learning module talking about translators and working with the population that happen to be deaf or hard of hearing, and making sure that we have this training on a regular basis. And so actually those modalities do function nicely to make sure that we're keeping the appropriate issues on the top of our minds.
Yeah, and from a provider point of view, it's called risk management. We want to cut down on the risks. And again, laws on the books are nice, but laws need to be enforced to have impact and have accountability.
I would like to add something. So I have a question, and my question is that doctors oftentimes pay to have their ratings on the computer changed in a more favorable direction. You can actually do that on both Yelp and on Google. I've seen some physicians do this. Also, I've personally experienced, because of my disabilities, people refusing to test or find out what was wrong, and it almost led to my passing because I had severe pancreatitis and I needed emergency gallbladder surgery. And I just feel kind of personal about this, like a personal, well, I actually have post-Lyme treatment syndrome, which is pretty controversial. My walking is greatly affected. And because of my other disabilities, I am dismissed a lot as well. And I would just like to see some of these things change. As far as litigation and taking any kind of charge, medical statute of limitations are very strict, and it's actually pretty hard to litigate or take a doctor to court for anything, frankly, even if they make a really huge medical mistake that lands you in a wheelchair for the rest of your life. I just like to see the system changed, because if as a direct result of a disability like mine, you're dismissed until you are completely disabled chronically, physically for the rest of your life, it just hurts a lot. And I was just wondering if there's more that can be done to ensure that even if you use the help law, that they can be held accountable so that you can get the support you need, so you won't meet your demise at the hands of a physician because of your disability.
I would like to make some private points here. Is that there is a lot of talk about disability and different abilities and all of that, because I have been through this. My mom is also an advocate for me, and also I'm an advocate to speak on disability justice as well, because I am not a person with a disability. I am not autistic in a wheelchair, but I see prejudice all over, because I am experiencing it in downtown Peterborough. Most people are on wheelchairs all of the time, and I have been experiencing that in downtown Peterborough, and because when I am speaking up like an advocate to find out how are senior citizens or other people with a disability do not know how to do things on their own and stuff like that. But for me, as a person with the label of different abilities, I do a lot to step up and advocate and stay on the same page with mom as well.
Thank you both, Cassandra and Forrest, for sharing. We just want to move on with the program a bit, so we're going to get to the breakout rooms now.
Hello.
We do want
Hi.
to thank Cassandra for her thoughtful comments, and we want to encourage you to get involved with ABLE. You can email at info@ablenh.org, and we would love for you to consider being on a team to create the change you just talked about wanting to see happen. And it takes a whole symphony of people, each of us playing our own instrument in order to make that change come true. So together we can make it happen. So I'm glad you joined us tonight, Cassandra.
Thank you, Lisa. Yeah, absolutely.
Breakout rooms, I guess that's me, huh?
No, that's okay. Just a quick reminder to everybody, if you are planning on sharing your stories, just to keep the names of institutions and healthcare providers anonymous, just out of respect. And this is just kind of a great way to re-engage with the panelists and with the subject matter. So thank you.
John, are we going to share the questions we'll be discussing in the breakout rooms before we move into them? Okay.
Yeah, that's a good idea. Yeah, we're going to be this is an opportunity to either, again, share what your experience has been, or ideas and solutions you have for these pressing issues in disability, with disparities in healthcare for the disability population. Yeah.
See you all in 1 minute. Go ahead, Cassandra.
I was just wondering if there could be increased funding for ombudsmans in like regular offices, perhaps, or some sort of person you can go to if you have disabilities and need reasonable accommodation to help you in your appointments. Something like a chaperone or something like that.
Yeah, I think that's a great idea. And I think that there are some places that have that. And what I want to recommend
they do.
that we discuss in the breakout room some of the ideas. And then what we're going to do is, for folks who might like to stay involved on this topic, we're going to take our ideas from tonight, put them all together, and then we're going to bring those ideas back to the D cubed, and then we're going to incorporate them into the work that's ongoing now that made this night happen. So definitely in the breakout room, let's make sure we get a notation of that, and then we can try to expand the role of ombudsmen across New Hampshire. That sounds like one part of an excellent solution. Leah, are we almost ready?
Okay. Yep, I am. Push the button. So you should be getting the invite now.
Why the three of us are not in a break?
So Lisa, you and I have to click to join one of them.
Okay.
You can choose.
Oh,
Dick is going to be in room number 2, and then John is in room number 3. So Lisa, I don't know which one.
I'll go to, well, Bonnie and Audrey, and I'll go to room 1.
Okay. Looks like as people drop down. Okay.
I still don't know how to get to my room.
You have to click the join that's up next to where it says join next to the room number in blue.
So that's where Erik is. And then who's in room 2? You're going to
Dick. It looks like some people might have dropped off the call, so there are less people in it now, unfortunately.
go to Dick's room now so that you can capture. Go to Dick's room.
Okay.
Right now, quick. And I will go. Yeah, there we go. we should have a commercial break on the breakout rooms and let Dick Cohen tell his 2 stories. You have to unmute though, Dick. You have to unmute though.
I'm so Zoom challenged. Speaking of challenges. So one story is this is about 30 years ago, do a quick version. I was at New Hampshire Hospital representing a young man who had mental illness. He'd been there for a while and his teeth were all screwed up, and he looked awful and he was self-conscious about it. So this was a treatment team meeting and Medicaid was available. So I suggested that the hospital look into getting him orthodontia. And they looked at me like I had dropped out of Mars, speaking of Mars, which I know we just landed on. So that's one story. Again, because what do you do for kids who have bad teeth? What does the middle class do? You get the teeth straightened. I mean, yeah. And if you have mental illness, you got enough problems, and so this would have helped his self-esteem. But again, they looked at me like I was, God knows what. I didn't file a lawsuit on that one though. The other one was, I remember that I was a court monitor in Minnesota and I went up to the institutions. It was a part of an institution that served adolescents who had behavioral and juvenile issues with some DD and learning disabilities. And I remember going up to a young man and I said to him, he was about 16, and just to, just for conversation, but also to learn a little bit about him, I said to him, what do you want to do when you grow up? Which is, of course, especially in my generation, I don't know if we still ask that question, you're always asked that as a kid, right? I mean, that's sort of the middle class ethos of America. And he said to me, you're the first person who's ever asked me that, and we were talking in the group about perception. So it's not just the medical community, but it's others as well who have these, they don't value people with disabilities in the same way they value everyone else. That was the context.
And so it sort of stemmed from, I was saying that my son Maxwell, his ears stick out really far. So did my dad's. It's an inherited thing. That because he has a disability, should we get his ears pinned? Should we not get his ears pinned? Like, who cares if he has ears that stick out if he's got Down syndrome and it's present all over his face? But I wanted his ears pinned, right? Because that's what we would do for any other kiddo.
Can I just add about the dental stuff? Actually, from what I understood, I worked in a dental office that depending on the level of malocclusion, basically how the bite is and how straight or crooked the teeth are, basically state insurance at some points does pay for orthodontics. So it's pretty shocking that they wouldn't even look into that at all.
Yeah, well, yeah, that was New Hampshire Hospital circa 1979. So
they used to have a dentist. They worked there for them.
Yeah, I know.
Anyway,
Dick also mentioned that there was, there's some reluctance to look into certain specific medical needs that only apply to people with disabilities. And I think speaking of dental stuff, like fused teeth, it's something that happens a lot with kiddos with Down syndrome. But it doesn't get a lot of attention in the general medical community because it's something that only happens to kids with Down syndrome and those with special conditions usually. So it's a form of exclusion, I think.
Yeah, absolutely. And there's actually a bill in the New Hampshire General Court addressing oral health care right now. So this is a lot of great topics. I hope we had a similar great discussion in our breakout rooms. If anybody would like to report directly from some solutions that came up or some bright ideas from the brainstorming, then now would be a great time to share kind of some next steps. And also keep an eye out on ABLE's Facebook page too, because we're going to keep the conversation going. So if anybody wants to chime in about what you guys chatted about, feel free.
Dick, it was nice hearing from you.
Dick, that's Derek Connery.
Oh, Derek,
Yeah.
thank you. And Derek's, it prompted me to, there was an issue that I thought of based on something he said and a few other things. And I don't even know the answer to this. It's just a question, and whether it's something that after you tackle cultural competency amongst doctors, you can tackle this one, is because there has been this bias, as in many professions, by the medical profession against people with disabilities or devaluing perception, whether the medical community or the health community nationwide, around the world, in Northeast, hasn't done sufficiently aggressive research to on issues that can be corrected through medical or surgical intervention. For example, people with cerebral palsy, and I don't know the answer to this, and I don't know what the possibilities are, where you can actually improve function, not just through education or through PT or OT, but actually through direct, sort of typical medical intervention or innovative typical medical, like surgery, et cetera. And then, of course, if there's not sufficient research and development, then you're not going to see innovative and aggressive stuff in the physician's offices either, because it usually starts with research and development by scientists and health professionals and so forth. So I wonder if the same bias that sort of makes them culturally incompetent and not view people with disabilities as disabilities and depressed parents and do all these things that Jennifer talked about and others have talked about, also has made them more reluctant and less aggressive in doing research that could actually help improve the quality of life of people with disabilities in any number of ways, and it would be an interesting discussion, because I'm just asking it. I don't know the answer. My suspicion is that there probably is not the level of research that you have for other populations, and therefore not the level of practice on the ground that you have with other populations.
I just have to give a shout out to Derek. Derek, it's Jennifer Bertrand. It's been a while. I know you're on the phone tonight. I don't see your face, but I just wanted to give you a shout out and say hello. I hope you're doing well.
It's good to hear from you again. I've been thinking very much in Abelville.
Yeah. Are you still in Ashwa?
Yes.
Terrific. I'm looking forward to the end of the pandemic, and maybe we'll see you at an ABLE meeting in the future.
I know someone else who needs to be involved. Erik Brand.
Okay.
I haven't heard from him in a while either. Erik Brand.
Yeah, I know Erik.
Yeah, he used to be involved, but he hasn't been involved in a long time.
Yeah, well, I'm sure the pandemic's had that impact on all of us. It's been a difficult time.
Okay.
So I would like to tell everyone what was discussed in the breakout room that I sat in. So really excellent conversation, and 3 really fun ideas is Cassandra talked about the ombudsman. And so how do we have a structured ombudsman program that is across New Hampshire with some sort of consistency and that is somewhat uniform and not just haphazard. Another one is we learned tonight that New Hampshire Family Voices has champions in healthcare, and it might be great to work with New Hampshire Family Voices to broaden that healthcare champions, so that we can dedicate more resources to making sure that that list grows if healthcare providers deserve to be on it, and that it reaches more families. So that's a second really great idea. And then another one is if we develop a really incredible gold star standard in a cultural competence training for healthcare providers that remains independent and continuously has a process of being validated by people impacted by disability and delivered by people impacted by disability. If we created that gold star standard of a CME training, then healthcare providers could put that on their websites or hang a sign, hang a framed picture in a framing of the fact that they have that all of the providers in an office have been through a gold star training, improving their cultural competence for people with disabilities. And I guess we would want to try to make eventually such a training inclusive of all populations that experience health inequities. But I think that would be a really terrific program. So those are 3 that we talked about in the group that I was in. Does another group want to share?
Lisa, do you want me to share about the group that I was in with John? We took we went person by person just to sort of get acquainted with each other and where we were coming from, and understand some of the struggles that each individual shared. And we didn't come up with so much some solutions about how to solve some of these problems, but certainly this group of women, there were multiple women that had some very similar experiences, and everyone in the group seems to have an interest in continuing to be connected and to work together to solve some of the challenges around and barriers that they've experienced through the health system, and either getting a diagnosis and being able to access specialists or medical providers that have the cultural competency to work with adults. And so we encourage them to stay connected. And I know that you have all of their information as well, but it seemed like that the group was very interested in staying connected and working together. One thing that I would say, though, about what the other group just reported on regarding, in addition to like the ombudsman type of thing, I mean, it really starts from like the university level where we're training doctors from the get-go. And I love the idea about the curriculum, but we have to start, when these doctors are in school, so that they have that comfort level and know how to interact and communicate with people who have developmental and other disabilities, and know, how important it is to make some accommodations so that people can access care. And the thing that I'm really excited about is the fact that ABLE has these partnerships with these medical professionals, like doctor that was on this evening, that it might have been in the field for some time now, but recognize the important work that needs to be done, and can even work from within, these groups and practices and networks to help educate doctors who are currently working, but addressing curriculum and ensuring that doctors in training have that exposure and that cultural competency is a really important part of that. And maybe with the continued work with ABLE, partnering and collaborating with medical professionals that are passionate about this will help us achieve that. And it might even interest young doctors. They might be thinking about and considering, like, maybe this is what I want to specialize in adult medicine. And that's how we can accomplish, increasing the number of adult specialists who are able to work with and have an interest in working with individuals who experience disabilities, intellectual disabilities, and so forth. Colby's got his hand up.
Hi, everyone. My name is Colby, and I just wanted to introduce myself and say that I work at Community Crossroads. I'm the digital marketing assistant. So I write blogs, I promote events, which are virtual these days. I help with setting up, putting stuff on the website. And a lot of my blog posts since I started are about inclusion and accessibility, and for people who have a disability, for their families. A lot of my stories are centered around either our area agency or the state of New Hampshire, and some of them even nationwide. And I think that this is my way of showing, because I graduated from Keene State in 2019 with a degree in journalism, and I also have a disability. And I think this is my way of showcasing my advocacy and using my voice to hopefully help people that read my stories say, wow, my child can do this thing, instead of being told by people, you can't do this, you won't do this. A lot of the story, all the stories I write about inclusivity, inclusion, and accessibility say, you can do this and you will do this, and here's how to be successful at it. So I just want to share that. Again, it's Community Crossroads. And follow us on Facebook or Instagram or whatever you have, because we're always posting really interesting stuff. And I would love to connect with any of you in the future if there's ever questions or anything.
Of course, with it, let me just put this, that still, you go into doctor, something that's still with it, a pet peeve with many of us persons with physical disabilities is the issue of, was it going into the doctor's office's exam rooms, and was it, you notice that the exam table, it's pretty high off, high off the floor.
Mhm.
Is it? And it's kind of tough for a person with a physical disability. Even if a person can walk, could take the with it, climb up onto the exam table.
Mhm.
For the doctor to take and look at you.
Yeah, there are a variety of different types of barriers, and those physical barriers can make it quite
The
difficult.
the
access
physical
care.
barrier is still there.
Yep.
So it ends up that my primary care physician, it just has me sit in one of the chairs in the exam room, and they do check my blood pressure and whatever, with it.
Yeah, one of the things that ABLE works on, Lisa, in terms of the whole concept of taking a universal design approach, in terms of, how we plan and build our public spaces, buildings, medical buildings, and taking that universal design approach could help, remedy. And it's important for people like us to maybe serve on those planning committees for our towns and our cities and communities, so that we can take a universal design approach and make things accessible to everyone.
Yeah, absolutely. Thank you so much for all of your participation. As you can see, this is not a conversation that takes place in the course of 2 hours or even 2 weeks or 2 years. So this has been really an absolute joy. This is our second panel, and we hope to do so many more. I want to give huge thanks again to our panelists, Dick Cohen, Lisa Beaudoin, Jen Bertrand, and Dr. Erik Shessler. What a phenomenal night. I just want to keep time in mind. If you have any other questions or you want to keep the conversation going, please look us up on Facebook, go to our website, ablenh.org, and please email me personally at any time, johnr@ablenh.org.
John, will you please share when the next Disability Diagnosis Dialogues Task Force meeting is?
I will. I don't know my calendar. It is, so we meet ordinarily the third Monday of every month. That's flexible, 9 a.m. So that's looking like March the 15th will be our next meeting.
Right, and task force members can change the time of the task force meeting when the group makes a decision to do that, to make sure it accommodates everybody's needs. But that's currently the day that the task force meets. And if that day doesn't work for you, again, get a hold of John.
Well, it is the Ides of March.
Uh-oh. All right, thanks everybody. I hope you have a great night.
Thank you.